Welcome to the Journal Club for this week. This study titled The Outcome of a Full and Deep Pulpotomy in Teeth with Extremely Deep Caries Lesion and Symptomatic Irreversible Pulpitis. It is a non-inferiority randomized controlled trial newly published in 2025. Previous histologic study showed that 62% of teeth with extremely deep caries lesion had inflammatory infiltrate which present in both coronal and radicular pulp. Therefore, the histological evidence indicate that the outcome of partial or full pulpotomy procedure may jeopardize with the presence of inflamed pulp tissue within the root surface. For this, they found that the removal of 2 to 3 millimeter from the coronal portion of the radicular pulp will improve the success. And this was reported previously in the literature under the term of high amputation or deep pulpotomy. So this clinical study aimed to assess the outcome of full and deep pulpotomy in teeth with extremely deep caries lesion and symptomatic irreversible pulpitis. Coming to the material and method, this study, designed as a parallel group, double-blind, unicentric, randomized, controlled, non-inferiority trial. They had a 65 patient with a mature mandibular first and second molar with extremely deep caries lesion diagnosed with symptomatic irreversible pulpitis and aged between 15 and 35, who were recruited to the department between April 2022 and August 2022. They did randomization through generate a sequence of random number and using sealed envelope. The patient and the outcome assessor were blinded to the study group. All procedures were performed through a postgraduate student under magnification and elimination. They start the procedure with anesthesia, then isolation, complete caries excavation, and access opening. After that, they assign the teeth into two groups. The first group, which is the full pulpotomy group, where complete removal of coronal pulp done and the time required for hemostasis recorded. The second group is the deep pulpotomy group, where 2 to 3 millimeter of radicular pulp was removed and also the time required for hemostasis was recorded. The two study group received a 2 to 3 millimeter of MTA and final resin restoration. Also, both group instructed to report a follow-up at 6 and 12 months or earlier in case of symptoms. The outcome assessment was performed with independent endodontic specialist with a 10-year of experience. And during the assessment, the coronal part of the X-ray was masked. To the study result, 5 teeth out of 65 were excluded as a bleeding could not be achieved within 10 minutes. No statistical significant difference in age and gender between the two groups found. A statistically significant difference in the time taken for hemostasis between the two groups and more time needed in the first group. 4 teeth in each group were lost during the follow-up, and the recall rate was 86.6%. In a 12-month follow-up, 52 teeth were assessed. In a group 1, 23 teeth categorized as success and 3 teeth categorized as failure, while in the second group, 25 teeth categorized as success and 2 teeth categorized as failure. The success rate in group 1 was 88.4%, while in the second group it was 92.3%. For the attention to treat analysis, there was no statistically significant difference between the two groups. The mean time required to achieve hemostasis was more in failed cases when compared to the successful cases in both groups. So to conclude, within the limitation of this study, there was no significant difference between full and deep pulpotomy technique in regard to achieving hemostasis and outcome. Thank you.